first one I'll comment on is, we were able to present an oral abstract presentation on the combination of Magrolimab with Azacitidine. This had been previously presented at the EHA Congress as well. And it's a pretty large study. So it's a phase 1b study, but kind of similar to, I would say, a large phase 2. 95 patients were treated. And really the safety has overall been quite good. So we do know that there is on-target anemia with Magrolimab. This is particularly the first week where patients can have large drop in hemoglobins. So to get around that, we do a couple of things. One, we keep the hemoglobin typically above 9 to 9.5 before their first infusion. We recheck them same day on the first 2 infusions, which are day 1 and day 4, as well as we do what's called a priming strategy. So they get a small baby dose of Magrolimab in the beginning that gets ramped up over the course of 2 weeks. And with all of that, if you look at 30, 60-day mortality, it's very, very low. And really, other than that, we're not seeing really unique toxicities other than sort of the cytopenia toxicities that we expect from azacitidine monotherapy. With immune therapies, such as Magrolimab, there's always concerns about immune-related toxicities. We've not really seen these. And then infusion reactions, which can happen to any antibody, do occur, but grade 3 reactions were quite rare, less than 10% of patients. So the safety has looked quite good. As far as efficacy, now over 70% of patients are responding with true complete remission rates in the sort of 30 to 40 percentile range. So kind of double from what we at least historically expect with azacitidine monotherapy. And we're seeing good depth in remission, cytogenetic clearance, MRD negative remissions by flow cytometry. And then I think what's really most important is really the durations of these responses. So the duration of CR is around a year. And then if we look at the first look into the overall survival, pretty mature follow-up of 17 months, actually the median overall survival was not met. And then what's highly relevant is I think partially because of early presentations and data, there's a strong or a high predilection of P53 mutant patients on the study. It was about a quarter of the group. So if you look at P53 specifically, the survival in that group was 16 months, which if you look at any prospective trial to date has not been greater than 12 months. And it makes the sort of rest of the cohort look somewhat better. Actually, 60% of patients were still alive at the data cutoff. We also showed, again, this encouraging transplant data where about 80% of patients were still alive at 2 years. So really all of it looks, highly synergistic and efficacious and really supports the ongoing ENHANCE trial, which is the double-blind placebo-controlled phase 3 study that we're actually all hoping to have the initial readout on that data before the end of the year, at least as far as is the complete remission rate truly improved. Again, that's never been proven in any randomized trial, today, and hoping that this may be the first one to accomplish that.